this video is therapeutic uses, adverse effects and contraindications of beta blockers. So this is a continuation of part 1 of beta blockers where we had learned the names of some of the beta blockers, the beta blockade actions and the responses on various tissues, the characteristic features of various beta blockers. So in this episode we will be discussing the clinical applications of beta blockers, the precautions, the adverse effects and the contraindications of beta blockers. So starting off with the therapeutic uses of beta blockers. The therapeutic uses of beta blockers can be categorized as cardiovascular and non-cardiovascular uses. So what are the cardiovascular uses of beta blockers? The beta blockers are used in various cardiovascular diseases. 1. Essential hypertension. 2. Congestive heart failure. 3. Angina pectoris. 4. Cardiac arrhythmias. And 5. Myocardial infarction. The non-cardiovascular uses of beta blockers are migraine headache, anxiety, glaucoma, hyperthyroidism, pheochromocytoma, alcohol withdrawal and variceal bleeding. Use of beta blockers in essential hypertension. Beta blockers are preferred drugs in younger individuals without any contraindications and in hypertensive patients with cardiovascular diseases such as angina, myocardial infarction or congestive heart failure. What are the blood pressure lowering mechanisms of beta blockers? Beta blockers, by blocking the beta-1 receptors of the heart, decrease the contractility and the heart rate, thereby decreasing the stroke volume and cardiac output, which is responsible for fall in blood pressure. Secondly, by blocking the beta-1 receptors of the kidney, they inhibit the renin-angiotensin-aldosterone system, resulting in decreased angiotensin II formation and aldosterone synthesis. Angiotensin II is a vasoconstrictor and aldosterone is responsible for increased absorption of sodium and water and increasing the blood volume. So beta blockers, by decreasing the formation of angiotensin II and aldosterone, decreases the blood pressure, decreases the peripheral vascular resistance and also decreases the blood volume, thereby help in lowering the blood pressure. Thirdly, the beta blockers block the presynaptic beta-2 receptors in the nerve terminals, which are facilitatory in character. So they facilitate the release of norepinephrine from the nerve terminals of the central nervous system. So by blocking the beta-2 receptors of the presynaptic nerve ending, there is decreased norepinephrine release. And decreased norepinephrine release leads to decreased sympathetic activity and a fall in blood pressure. So together, a decrease in the cardiac output and peripheral vascular resistance and also a decrease in the central sympathetic outflow contribute to the lowering of blood pressure. So the second use, beta blockers are preferred drugs in the management of congestive heart failure. As we have learned that in heart failure, there is failure of the pumping mechanism and the heart fails to pump blood in the forward direction, resulting in decreased cardiac output and perfusion to vital organs. So sympathetic system supports the heart in maintaining normal cardiac output. So what is the rationale for using beta blockers that block the beta receptors and inhibit the sympathetic activity in congestive heart failure? The beta blockers are useful in heart failure by inhibiting the beta-1 receptors of the heart that decrease the contractility, heart rate, thereby decreasing the workload on the heart. And when the workload decreases, the oxygen demand on the heart decreases, the oxygen consumption decreases, and this has a beneficial effect on the heart muscles. Secondly, blockade of beta-1 receptors of the heart has a positive effect on cardiac remodeling. So by preventing cardiac remodeling, mortality and morbidity decreases, and this is beneficial in patients with congestive heart failure. Beta blockers, by blocking the beta-1 receptors of the kidney, inhibits the release of renin and the renin-angiotensin-aldosterone system, decreasing the angiotensin II formation, which is a vasoconstrictor and increases the afterload. Also, aldosterone synthesis is decrease, which decreases the preload on the heart. So by decreasing the angiotensin II formation and aldosterone, the afterload and preload on the heart decreases, and this is beneficial in patients with congestive heart failure. So beta blockers are useful in congestive heart failure by decreasing the workload on the heart, by preventing maladaptive ventricular remodeling, decreasing the mortality and morbidity in patients, and improving the survival in patients of congestive heart failure, and also decreasing the preload and afterload on the heart by inhibiting the renin-angiotensin-aldosterone system. Next use. Beta blockers are effective drugs in the management of chest pain or angina pectoris. Angina pectoris is due to an imbalance in myocardial oxygen consumption and myocardial oxygen demand. So, beta blockers, by blocking the beta-1 receptors of the heart, decrease the myocardial oxygen demand on the heart, thereby decreasing the workload on the heart, and is helpful in relieving the symptoms of angina. Also, it is to be noted that beta blockers are contraindicated in Prince-Metal angina or vasospastic angina characterized by localized vasospasm of the blood vessels. So, beta blockers, by blocking the beta-2 receptors of the smooth muscles of the blood vessels, result in unmasking of the alpha-1 receptors, and the action of alpha-1 receptors results in excessive vasoconstriction in the blood vessels, aggravating the vasospasm in the peripheral blood vessels, and this leads to worsening of symptoms of peripheral vascular disorders such as frostbite, Raynaud's syndrome, and so on. Beta blockers are effective drugs in the management of cardiac arrhythmias. Cardiac arrhythmias are due to an abnormality in automaticity and also an abnormality in propagation of electrical impulses. Beta blockers are effective drugs in the management of atrial fibrillation, a disease characterized by abnormally rapid heart rhythm and heart rate. So, beta blockers, by increasing the refractory period at the AV node, decrease the AV conduction and thereby helps to control the ventricular rate in atrial fibrillation. Secondly, beta blockers inhibit the automaticity in the latent pacemakers of the heart and also at ectopic sites that are responsible for abnormal impulse generation. A non-selective beta blocker such as propranolol has membrane stabilizing action which contributes to its antiarrhythmic action as a beta blocker. The next use. Beta blockers are useful drugs in myocardial infarction. By decreasing the heart rate contractility and the workload on the heart, the size of the infarct decreases. Secondly, beta blockers decrease the threshold for ventricular fibrillation and decrease the mortality and morbidity in patients with ischemic heart disease. So these are some of the cardiovascular uses of beta blockers. So beta blockers are useful drugs in the management of hypertension, congestive heart failure, angina, cardiac arrhythmias, and myocardial infarction. In beta blockers, we have cardioselective beta blockers and non-cardioselective beta blockers. The cardioselective beta blockers such as metoprolol, atenolol, bisoprolol, and newer generation beta blockers such as nebivolol, labetalol, carvedilol are useful in the management of cardiovascular diseases. The cardioselective beta blockers are preferred because they have highly selective action on beta-1 receptors of the heart with minimal action on beta-2 receptors at other sites. Therefore, cardioselective beta blockers are safer in the management of cardiac diseases with associated factors such as bronchial asthma, diabetes mellitus, and peripheral vascular disorders. Some of the cardioselective beta blockers are metoprolol, atenolol, bisoprolol, betaxolol, and so on. Nebivolol is a new generation beta blocker which has the unique property of increasing the nitric oxide synthesis and promotes nitric oxide mediated vasodilatation and decrease in peripheral vascular resistance, resulting in a fall in blood pressure. Secondly, nebivolol has an anti-atherosclerotic property which is beneficial in patients with cardiac diseases. In addition, it improves the blood flow and benefits patients in congestive heart failure and reduces mortality and morbidity in such patients. Labetalol is a mixed alpha and beta blocker. By blocking the beta-2 receptors of the smooth muscles of the blood vessels, it results in a fall in blood pressure due to vasodilatation and decrease in peripheral vascular resistance. Blockade of the beta-2 receptors results in unmasking of the alpha-1 receptors of the blood vessel, resulting in unopposed vasoconstriction. So labetalol, by blocking the alpha-1 receptors, further reduces the peripheral vascular resistance, resulting in a fall in blood pressure. So both alpha-1 and beta-2 blockade action results in a fall in blood pressure, but the side effects are hypotension and dizziness. Carvedilol is an alpha and beta blocker with a unique antioxidant property which reduces oxidative stress in patients with cardiac diseases. The non-cardiovascular uses of beta blockers are as follows. 1. Migraine. 2. Anxiety. 3. Glaucoma. 4. Hyperthyroidism. 5th. Pheochromocytoma. 6th. Alcohol withdrawal. And 7th. Varicose bleeding. Use of beta blockers in migraine headache. Beta blockers reduce the cerebral blood vessel dilatation, which is known to contribute to migraine headache. Beta blockers also reduce the electrical activity of the nervous system, and the electrical activity is responsible for the migraine aura. So beta blockers are used as prophylactic drugs for the management of migraine headache. Next, use of beta blockers in anxiety. Beta blockers are known to reduce anxiety, restlessness, tremor, which is mediated by beta-2 receptors of the skeletal muscle. Next, use of beta blockers in the management of glaucoma. Beta blockers such as timolol and bitoxolol are preferred drugs in the management of wide-angle glaucoma. Timolol is a highly efficacious and potent drug in reducing the intraocular pressure compared to bitoxolol. This is because timolol is a non-selective beta blocker, blocking the beta-2 receptors in addition to blocking the beta-1 receptors. This is because most of the beta receptors on the ciliary body epithelium that are responsible for formation of aqueous humor is of beta-2 subtype. So by blocking the beta-2 receptors, timolol serves as a highly efficacious drug in the management of glaucoma. However, bitoxolol is less efficacious than timolol because of minimal action on beta-2 receptors. But the advantage of bitoxolol is that it is safe in patients with bronchial asthma, diabetes mellitus and peripheral vascular disorders because it is a cardioselective beta blocker having action on beta-1 receptors with minimal action on beta-2 receptors. The next use, the use of beta blockers in hyperthyroidism. Beta blockers reduce the symptoms of hyperthyroidism, which is due to excessive beta-adrenergic tone such as anxiety, sweating, palpitation, tachycardia, tremor. Propranolol, a non-selective beta blocker, has an additional property of reducing the conversion of T4 to T3, which is the active thyroid hormone, and thereby helps in reducing the symptoms of hyperthyroidism. Therefore, it is a preferred drug in the management of thyrotoxic crisis. The next use, beta blockers are used in combination with alpha blockers in the management of pheochromocytoma. Pheochromocytoma is a tumor of the adrenal medulla that causes excessive secretion of catecholamines, that is epinephrine and norepinephrine. Excessive release of epinephrine and norepinephrine results in increased sympathetic activity and hypertensive crisis. So beta blockers counteract the beta-1 mediated tachyarrhythmias that result from alpha blockade action with use of alpha blockers. The next use, the use of beta blockers in alcohol withdrawal. Alcohol withdrawal is associated with increased sympathetic nervous system activity such as hypertension, palpitation, restlessness, tremor, anxiety. So beta blockers, by inhibiting the sympathetic nervous system, helps in the management of signs and symptoms associated with alcohol withdrawal and helps in alcohol de-addiction and rehabilitation. The next use, beta blockers treat variceal bleeding by reducing the cardiac output and inducing splanchnic vasoconstriction. So this helps to treat variceal bleeding. Next we move on to adverse effects and contraindications of beta blockers. 1. Beta blockers are known to cause bronchoconstriction of the airways. The non-selective beta blockers block the beta-2 receptors that are responsible for bronchodilation and relaxation of the airways. By blocking the beta-2 receptors, they increase the bronchial smooth muscle tone, thereby increasing the symptoms of bronchial asthma. Therefore, they are administered with caution in patients with bronchial asthma, and cardioselective beta blockers are preferred over non-selective beta blockers. Secondly, beta blockers are known to cause bradycardia as a side effect because they decrease the contractility of the heart and also decrease the AV conduction. Excessive lowering of the heartbeat to less than 55 beats per minute can lead to bradyarrhythmias and atrioventricular conduction block and disturbances. Next, beta blockers can cause cold extremities. This is due to loss of beta-2 mediated vasodilatation and decrease in blood flow to the skin and mucosal membrane, resulting in cold extremities. Beta blockers are also known to cause fatigue because of decreased cardiac output and poor perfusion to the skeletal muscle. Sleep disturbances, bad dreams, depression are other CNS side effects of beta blockers. Beta blockers are contraindicated in decompensated heart failure. The heart failure patients require some degree of sympathetic drive to support the heart to maintain the normal cardiac output. So patients with hemodynamic instability should be administered beta blocker with caution as it can lead to cardiogenic shock. Beta blockers block the sympathetically mediated symptoms of hypoglycemia such as tachycardia, palpitation, sweating and tremor. So by inhibiting or blocking the symptoms of hypoglycemia, the patient may go into hypoglycemic unawareness. This leads to delayed recovery of hypoglycemia. Next, beta blockers should not be stopped abruptly. Sudden withdrawal of beta blockers can lead to rebound hypertension and anginal attacks. Chronic therapy with beta blockers lead to upregulation of beta adrenergic receptors. These newly synthesized beta adrenergic receptors show hyper-responsiveness to even smaller doses of catecholamines. So this leads to rebound hypertension and anginal attacks to even smaller doses of catecholamines. Therefore, beta blockers should be withdrawn with gradual tapering of the dose. Sudden discontinuation of beta blockers is discouraged in patients with antihypertensive therapy with beta blockers.
These are my references. Thanks for watching. Please like, subscribe and share.